like to present myself once again, since I'm the chair and I have nobody to present me. As said, I'm a pediatrician and I work with children with immunodeficiencies in Sweden. And I have to congratulate the organizing committee for putting up this session in this very logical way, that first talking about patients, the patient's perspective, then the doctor coming in, and in the end the industry, the pharmacies point and what they can give us for help. So what I'm going to talk about to you today is very shortly what is immunoglobulin, what are the today known indications, what is the approved indications. I will talk about the Ivig and I will talk about the subcutaneous SCIG treatment, both advantages and disadvantages. And I will give you just some slides about how it looks in the rest of the world. So to start, what is immunoglobulin? I'm sure that most of you know it. I just would like to give it maybe to the younger people who have not that much experience. It's made from pooled plasma for more than 1,000 donors. So each batch you are giving to your patient contains antibodies from 1,000 or more people. And it's a treatment that provides replacement, and it's replacing basically what you are missing. And what is replacing is IgG. So over 95% of all available products contain IgG. There is a little IgA, and there are different constituents, which is the rest of the percentage to 100%, and is different from each product. But the main point is that it's 95% IgG. There is lots of safety issues since the 80s, and all the companies are having really strict, rigorous techniques to make this product safe. And why do we need this to give to the patients, and why don't we produce it recombinant technique or something else smarter? Well, the point is that the antibodies, there's such a huge variety of antibodies in each of us that we just basically cannot manufacture all that amount of all those different antibodies. So we have to have the patients who are the blood givers who are giving us the antibodies. This is just a short time slide. What I wanted to make you see that actually the first patient who received from Bruton 1952, he actually started with subcutaneous treatment. But he had two colleagues, Janeway and Gitlin, who were the big names in immunoglobulin research and immunodeficiency research, and they were more for the Ivig. That's why and the intramuscular treatment. The Ivig was not safe, gave lots of adverse effects, but in 1980s sometimes we started giving a more safe product, and it became the golden standard. At the same time, we have some reports from the beginning of the 80s with the subcutaneous treatment, and actually the reason why I'm here also is because in Sweden already in the beginning, in the middle of the 80s, beginning of the 90s, we had pretty many patients on subcutaneous treatment. So the Nordic countries, Scandinavian countries, were pioneers in introducing subcutaneous treatment. And then the first subcutaneous treatment was licensed in the US, and then the big boost of subcutaneous treatment came. And then one milestone was in 2013, but that will be the next talk, so I'm not going to say anything about that. What are the approved indications for today? Well, obviously primary immune deficiencies, where all of them where you are missing the IgG are approved indications. However, there are some more indications where you are looking for the immunomodulatory effect of the immunoglobulins. For example, the first description was the ITP, the idiopathic thrombopenic purpura, but there are lots of other indications. And to make it even more confusing, there are lots of more approved criteria with additional criteria. Both hematological, neuromuscular diseases, and dermatological diseases. So the list is getting bigger and bigger. How should you select your patient who you want to give immunoglobulins to? Well, there are two things. First, you have to define what the problem is, because you have to remember, testing the patient after you started giving the IgG, it's not possible. You are measuring what you're giving. So test before. Our recommendation, at least in the Nordic countries, is that we are using these patient diaries and to monitor how they are doing before and during the treatment. And then you have to be honest with your patient and let them know that they are receiving actually a blood product. It can be risks with infections. You just have to tell them what are the risks, what are the benefits, and let the patients also decide if they want this or not. And there is one more option. Sometimes we are not sure if this is going to help or not, and then our recommendation is always that we should go for a trial period of 6 to 12 months. And my personal experience is that I would prefer to have the patients to sign an agreement that we are just doing a trial period, because once you started a patient with IgG treatment, they are feeling much more better, even if they don't really have a big need of it. And it's very difficult to tell them that I don't want to give them anymore. For those of you who are considering starting a patient, I would recommend very much this paper published not so many years ago from one of my mentors when I worked in the United States, Professor Cunningham-Rundles, and she made this table where you have, it's not too complicated, it's the amount of points which you can get depending on the laboratory or clinical history of the patients and some lung function test. And what they are saying is that if you have a laboratory score over 10, then you should definitely start the patient. If it's lower than 10, then you should take in account the clinical history, and then you have this very nice flow schedule for making some kind of decision if you want to start IgG or not. And should you choose IVIG or SCIG? Well, there are advantages and disadvantages. I will come to that. One thing that I want you to remember, that you give IVIG, you have a very high level of IgG the first days, and then that slowly goes down. While with subcutaneous treatment, you have a more continuous, more stable level. And with the IVIG, you have this period when the trough levels, when the levels are much lower than in subcutaneous treatment, and it's a window for infections to start. About the dosage, the recommended dose today is 0.4 to 0.6 gram per kilo body weight every 4 weeks. That's just a general rule. For the subcutaneous treatment, it's the same total dose for the month, except that you're giving it weekly. And it's a very clear-cut relation. The more you give, the higher the trough level of IgG will get. And why is this important? Because in this very nice study presented now 5 years ago, they have shown a very clear linearity between the level of IgG at the trough level and the number of pneumonias the patients are getting. So the more IgG you give, the less risk for the patient to have pneumonia. So how about what do you choose? Which one should you go for? Well, IVIG, you have to treat the patients only once every 3 to 4 weeks, so once a month, while with SCIG you need treatment weekly. IVIG, however, the treatment takes 2 to 3 hours, while the SCIG much shorter. For the IVIG, you need really good venous access. Can be difficult, especially for children who are afraid of needles. The adverse effects I'm going to return to. Home therapy is possible for both of them, but it's more complicated with the IVIG because it needs good venous access and requires trained personnel. On the other hand, for the subcutaneous treatment, you need a patient, or in my case, the patient's parents, to be able to infuse the immunoglobulin. This I already mentioned, that the IVIG goes very high the first 2 days, while in the IV treatment and then the subcutaneous treatment is a more consistent level. With SCIG, you still need some pumps, which the patients have to have, which can be issue problem with reimbursement in some countries, while in IVIG you don't need those pumps. The advantage for IVIG that can be given in patients who have bleeding disorders, and this is not recommended, however, for patients with SCIG. However, for those patients, it fits for those who have problems traveling and who live far away from the center where the IVIG can be given, so that's why it fits more them. The patient feel more free. They can decide if I want to take my subcutaneous treatment on Saturday, or I want to take it on Monday, or I want to take it in the morning or in the evening. So the autonomy is increasing. And actually they have been some studies publishing that it's actually cheaper. About the adverse effects, both of the treatments have these ones in the middle where headaches, migraine, and in very rare cases aseptic meningitis have been shown. Fever, chills, fatigue is very common in many patients. And the difference between these two are that the IVIG you are in the risk zone to have anaphylactic reactions, while for SCIG it's mainly local reactions that is the problem. And the recommendations are whenever these adverse effects appear, then you should start lowering the infusion rate, and that's my experience also, that usually the side effects are much less severe or disappear completely. And this is a slide which I put together with it's not one study, but this tries to show the number of patients having, the percentage of patients having systemic adverse events. And about 25% of intramuscular treatment, about 45%, 46% of the IVIG, and almost no systemic adverse event for subcutaneous. I guess you can realize where I'm heading to. A big meta-analysis done in 2012, actually, on very many publications, 156, and many patients evaluated, and they showed very clearly that the patients and the effect of subcutaneous treatment is much better than of IVIG for all the parameters they looked at. And for those of you who have problems getting the pumps, they have been published recently, fairly recently, some articles from the United States where there is a center very successful with a so-called alternative treatment with subcutaneous, so-called rapid brush treatment. And that means that basically the patient sometimes daily infuses 5 to 20 milliliters of immunoglobulins, just a quick injection, and then they go off to work or school or whatever. No need for pumps, no need for complicated procedures. Not something that I would recommend for my pediatric patients, considering how afraid they are usually of needles, but for adults, for some of the patients, it's actually an alternative, and you don't need the pumps. The quality of life of patients are increasing. This is a study done by a colleague of ours from Sweden, and very clearly have shown, especially for children, when you use quality of life measurement after start of subcutaneous treatment, it's a significant, also in the adults, but in children it's even more. And for the international, last slide, the international perspective, don't look at the numbers, just look at the colors. The lighter the color, the more the patients are receiving subcutaneous treatment across Europe, both for adults and children. As you may see, Scandinavia is very light blue, while Russia, Southern Europe is more dark blue. And this is the percentage of patients receiving the different type of treatments. And as you can see, Sweden is an outlier. We are having more than 80% of our patients on subcutaneous treatment, and as a pediatrician I can say I have less than 5 patients on IVIG. All the other ones are having subcutaneous treatment. I do believe that it's better for the children and for the families to do it at home, not having the trauma of coming to the hospital and not needing the venous access. And the last slide, which I want to tell you, that you need the patient to be, at least in our experience, you need to talk with the patient, because you have one set of ideas, the patient thinks of totally different things. So in order the treatment to work, you need a patient to be able to choose or have his word about the treatment choice. And this is the picture taken 2 days ago, a family of 3 boys with XLA. And as you can see, they prefer the subcutaneous treatment.